and provide, long-lasting immunity, because everybody wants remission.
Yeah.
1 year, 5 years. But I mean, we're after decades where it's not remission, but it's what? Cure at that point.
Yeah, exactly. Yeah. I mean, these are, with immunotherapy, cures are possible, right? And for advanced cancers, which, normally would not be the case. Certainly with chemotherapy is not the case.
You mentioned about T effector cells versus T regulating cells, because it's what immune cells they are and what are they doing to that environment. So, when we look at, particularly there's, myeloid-derived suppressing cells, T regulating cells, they create an immunosuppressive environment there. So it makes it very hard for the immune system to act. But ivermectin really seems to go in there and provide a tilt, a balance.
Yeah.
It suppresses myeloid-derived suppressive cells, and then it shifts that T effector, T regulating cell. And I think people think from a cancer perspective, Jason, they think of this kind of ball of cells isolated from the body, but that's not the way it exists. So if you could really try to paint a picture of how this ivermectin, not systemically here, intratumorally, how does this change the environment and really the dialogue between the immune cells that are there, and the cancer?
Yeah. Yeah. So it's obviously what we're, look for in any drugs such as like ivermectin or other drugs. We want drugs that will, decrease more of the cancer protecting immune cells, because, again, the immune system has the two sides. It has a side that will protect and help the cancer, and it will help, and has a side that will attack the cancer, and they're very much alike, right? So there's a lot of times where there's things that you might target it, you're killing both, right? So it's like you got a war going on in there, and you're trying to arm the right sides, but you can't really tell who's who. And so this is, the situation with cancer is that you want to try to do the things that favor, that are the anti-cancer. And so, ivermectin seems to have a little bit of a more benefit towards that anti-cancer side of things. And there's other drugs that obviously we do that. So that's why we try to weigh all that and try to boost the immune response. It's all anti-cancer with simultaneously not reducing, as much of that. Well, we want to try to keep that all anti-cancer, and again, some of these drugs are very non-specific. So if you're affecting immune cells, you could affect it on both sides. And so how do you determine those little specifics? Really, really difficult. And that's a challenge in cancer treatment. But yeah, there are certain drugs that, favor those that will, attack cancer. And that's kind of what we try to load toward that side of things.
Everybody looks at ivermectin, they think about its oral use, which I think it kind of falls into that. Well, let's give this IV. So it's the same kind of processing. There's one way to give therapies, it's IV and it's oral. And it really, a lot of people, as it relates to ivermectin, don't realize that beyond the oral, and understand that it's very lipophilic. And so there's some issues related to dosing there. It tends to be safe when properly dosed. Of course, there can be toxicity associated with it. And that's what that ER doc was referencing last night, is this patient was self-medicating with ivermectin. And I think in that instance, the doctor was absolutely correct in saying that, the patient shouldn't be doing this. But in essence, this patient had nobody to turn to. And so in essence, created a toxicity profile. But looking at beyond oral, there's transdermal, ivermectin being useful to treat in rosacea, acne, rectal, actually being used in colorectal cancer animal studies, nebulized, intraperitoneal, which I think is really interesting, Jason. We could talk about that as it relates to people that just have like carcinomatosis.
Right, sure. Yeah.
But in the intratumoral, there was a study that an in vivo looking at xenograft, which is a tissue that is transplanted between individuals of different species. And they were looking at ivermectin here. And it was really amazing, because what they found is that in different types of cells, but here particularly they're looking at glioblastoma, they actually found a 50% reduction in tumor volume with the intratumoral ivermectin. Now, that's glio.
Yeah.
We wouldn't be injecting that into a glioblastoma in the brain, but here's a mouse model where they're actually injecting intratumoral ivermectin, and it's reducing the volume by 50%, and it's at 3 milligrams per kg, which is kind of low.
Yeah, exactly. Yeah. I mean, it's like any drug. You think your effect, if you're trying to get cancer, if you put it in the cancer, that's where that's where you really want it to work at. So that's if you can put more of the drug there, that tends to be a better option.
And really, I think most of the target the side effects, the adverse events associated with therapies are a result of overdosing and off-target toxicity.
Exactly. Yeah. Yeah.
You're trying to get to the tumor, you're trying to go through the body to get there, and you overdose and you get problems.
Yeah, I mean, if you look at dosing IV or oral, how much of that drug gets to the tumor? Very little, little, right? So, whereas so let's say, I take 100 milligrams of drug X by mouth. My cancer, let's say it's located in the liver, what does it see? It sees 2, 3, 4 milligrams of that drug, maybe. Okay. Or what if I then take 50 milligrams of the drug, I inject it right in the tumor. I cut my dose in half, so I don't even have the toxicity issues. I put it all right in the tumor, and so that's the way to go. I mean, it's obviously any things that you can put in right in the tumor are going to be much better.
And it helps you to create immune activation right there against the tumor.
Yeah, you get a whole different level. I mean, think of it this way: they're seeing immune infiltration and heating up these tumors by taking 40 and 60 milligrams of ivermectin orally. But okay, what if you put 40 milligrams of ivermectin in the tumor? Because that's at that level, the tumor's seeing very little. The oral, right? It's going to see 2 milligrams maybe. But what if I put 40 and now just load? I mean, that's a whole different deal, right? I mean, so when you put it in the tumor, it's much, much better.
And for the most part, it stays in the tumor, right?
Well, it'll circulate out some. I mean, there's various ways that we do have stuff that we'll put things like in gels, and we'll do stuff to try to hold it in the tumor. So we have various forms that we can do that maybe even keep things at like slow release. So there's various options on that. But, still, even one of the things is that, like when you're injecting in tumors, and let's say whatever the drug is, this is the thing I always tell the other doctors I work with. When you push a drug, you push it slowly because you can watch it and you can see it like on ultrasound. You see the drug flow around. You want it to have the time to interact with it. If you just slam it, right? You just what they do, they take a syringe and just push it. That just shoots it all away, right? But what you want to do is watch it flow in the tumor and see it, and then you see it like interacting with it, right? That's what you see actually happening, and so that's why you push these drugs very, very slow when you're in them, and allow that.
So you're watching it in real time.
Yeah. And so this is something that you can see, particularly like when you're doing like ultrasound in real time, and you can watch and you can see that, and you can see that drug flowing in the tumor, and so when you do it, you want to push it really slow, because like boom, and you can see, and you can tell the drug's bonding, right? So you do it a little bit. You have to push at a slow rate. That's the thing. But medicine, they always want to they want to do procedures fast. They want to do things fast. So boom, like what they do. If you go get a vaccine or whatever, they stick you in your arm, they jam that like in the second, right?
Yep.
But that's not how you do it.
And that's important because
we've looked at this. So we put you can put them on like a little pump and like run it really slow, or you could just do it with your hand. But you gotta watch and do it slow. There's a technique to it.
Everybody focuses on dose. I mean, this is getting down to what are called pharmacokinetic properties. But it's not just dose, it's also duration. And that's what you're kind of getting into.
Yeah.
It's really the combination of those that really empower the benefit of whatever therapy that you're using. So let me mention something. We're talking about ivermectin. You've mentioned vitamin C, which obviously I'm a huge advocate, big advocate of it intratumorally, obviously, because the animal research supports it and it's safe. And it bypasses all the limitations of the systemic, just like you would see with chemo or immunotherapy. But, what when we look at this, you were touching on the concept of lower dose because it's going into the tumor.
Yeah.
And this animal model really says that without saying it, because they followed for 10 to 42 days of treatment, oral, intraperitoneal, and intratumoral. The most common was the intraperitoneal, but the median dose in the mice, they're going to be much higher dosing, was at 2.4 to 40 milligrams per kilogram, which was equivalent to 0.4 milligrams per kilograms in humans. So looking across different delivery methods here, but most of it was intraperitoneal, but it was a lower dose. And when you actually look at where the literature suggests, I believe, in terms of treating cancer, yes, in that pulsatile approach, as you mentioned, it's 0.2 to 0.4 milligrams per kg. And this study is showing it in mice, but they're extrapolating that to a human equivalent dose. But it ties into what you said. Oral, there's one dose. Intratumoral, there's a significantly lower dose. We're taking it right to the point of action.
Exactly.
But it's not just the thing. You're injecting other things with it.
That's why it allows you to use these combinations. So then you start looking like at your monoclonals, which are real heavy hitters on like T cells and other stuff like that. Drugs like, well, I mean, you obviously got your things like a CD40 agonist. Inject that right into the tumor. You've got, look at like your checkpoints, PD1, LAG3, things like that, B7H3, all those as well. But, you can cut your dosing down. I can never give the patient the systemic dose of all those things, but I can give them, a mild dose of all of them together. So then that's what we start seeing in concert, where what we're doing is we're injecting the patients with all these different things, like, anti-CTLA-4, CD40, CD47, all hitting all these different targets all together simultaneously in the tumor to make the immune response happen.
Yeah, you mentioned systemic dose, but how much, and you've already touched on, how much of that systemic dose actually gets to the tumor? Not just gets to the tumor, gets to the tumors, because in so many cases, our patients, they have a large tumor burden that's wide distributed throughout the body, but it's about actually saturating the tumors. And so you're really bypassing every limitation that there's an issue. And so many people, and at least that conversation last night, they were talking about toxicity, because this gentleman had come in and he was unconscious because of his self-medication of ivermectin. But it's really interesting. He quoted a wrong dose. He said toxicity can occur at 30 to 40 milligrams. He wasn't talking about kg, and there's not evidence for that, because when you look at the human equivalent dose of the lethal dose 50 in mice, it's 2.02 milligrams per kg, meaning take your weight. So for a 200-pound man, that's going to give you a toxic dose of about 182 milligrams. And for a 171-pound female, which this is average in the U.S., it's 155 milligrams. And this needs to be taken on a repeated basis. So you're talking about, no, we lower the dose, we target the tumor, and it's pulsatile. So the toxicity is, I guess toxicity is always there no matter what treatment is there, but you're taking the risk way down.
Your toxicity from the drugs really goes down, where you run into issues is just the immune response against the cancer at that point. And so that's a different type of toxicity, where now your immune system is attacking cancer. So you want to get it attacking the cancer, but you do want to get it somewhat controlled, because depending on the patient's tumor volume, right? If the patient has a lot of cancer, then you want the immune system to attack it, but you don't want to necessarily kill it all today. You want it to do it a little bit. So you got to do it as a process. If a person has a little bit of cancer, that's a different story. You could really get the immune system after that, and the body will handle it. But a patient with a larger load, you've got to be more cautious, and because you don't want the immune system to just overly aggressively attack all the cancer at once. That will be a shock to the person. So that's a challenge of trying to get the immune system after it, but not too much. And again, a lot of it depends on the amount of cancer the person has. The more cancer the person has, the worse it is. I mean, you give me somebody with very little cancer, that's much easier.
In fact, we love to see all patients, but we know those patients are going to do very, very well, because in most cases, their immune system's fully functioned. They've not had the damage of all the sequelae associated with treatment. But one of the interesting things that's really got me intrigued here, because, a lot of what we'll see when you look at many different cancer types is where they get this peritoneal carcinomatosis, where there's just cancer all over the abdomen and the pelvis. It's everywhere.
Right.
But there's not maybe a big dominant mass. So it's just pebbles everywhere. And it makes it very difficult to treat. Most of these mice and rat studies, and they've done rabbits, they've done monkeys, they've done dogs, is that they've done it intraperitoneal. And I find that really interesting because in some of our patients, you've mentioned actually that there were no direct tumors, so you just injected the intratumoral immunotherapy into the peritoneum.
Right, we do that.
Because there was not anything to ablate.
Yeah.
But from a conventional standpoint, they will actually inject chemo, will they not?
Yeah, you can.
They will inject chemo with heat.
Mm-hmm.
I bet. So really, I wonder if ivermectin could be used, obviously, for intraperitoneal carcinomatosis.
Yeah.
In conjunction with immunotherapy, but maybe even chemotherapy.
Yeah. Yeah. Well, lots of options. Yeah. When you have intraperitoneal disease, the peritoneum has a different immune environment. That's one of the things that you always look at, like in these cancers, like where if a tumor is located in the liver versus the lung, those are different immune environments. And the peritoneum is a environment where the immune system's a little bit more lax, right? Because like that is where a lot of the blood flow, like when you're draining from intestines and stuff, goes in there, and it's kind of designed to not attack everything that you eat. So it lets things, it's a little more permissive, and that's why cancer can exploit that. And so we've looked at various drugs. It turns out to be there's this plasminogen activator inhibitor number 1, SX682, that works really well in that environment. I mean, there's like certain immune things that you do that, depending on where you're targeting. But yeah, that's certainly an issue.
So did you ever see yourself innovating like this when you decided you wanted to do radiology? Not just that you're targeting the tumor, but you're really targeting with repurposed medications by repurposing their delivery.
Yeah.
Did you ever see yourself doing this when you pledged or, when we went up there and stood and found out where we were going, what was that called? It wasn't the white coat ceremony.
Match day.
Match day. Oh my gosh. Yeah. Oh, the stress associated with match day.
Yeah.
Did you ever see yourself doing this?
Yeah, I don't, I mean, I guess I did and I didn't. I mean, I was kind of trying to go this way. Obviously, I really wanted to work in cancer, really wanted to try to find, a cure for cancer. Certainly had seen lots of things I thought were promising and thought that could work in that direction. I think things have been, obviously a little bit different than I ever expected it would be. But and definitely, we're having to look at these a lot more complex combinations. But yeah, you really do need to be able to deliver your therapies to your targets. I mean, if you're wanting to treat an area, and so that's why interventional radiology is so great, because we have the ability to access specific areas and treat that spot, not necessarily the whole body, because things in the body do differently, right? I mean, if you got some in the lung versus the liver, that's not the same, right? So you want to put it in the spot. So
and we talked about a little bit about intraperitoneal, just injection of the immunotherapeutics here, ivermectin. I know conventional does chemo under heat, IVAC it's called, and so they inject that into the peritoneum, peritoneal cavity, excuse me. But what you're doing here is you're bringing the delivery to the body, but to the tumor.
Yeah.
And you're providing the means to two things happen: target the tumor and heal the body.
Mm-hmm.
And I don't think medicine has done that well. And I don't even think that those two are possible. Yeah. But I've been working with the team now for it's amazing, about 9 months.
Yeah.
Most of our patients, Jason, they feel better and they get stronger as they go through therapy. Now, obviously, there are, cancer is cancer. So there are times where the body just struggles and the person struggles. But most of our patients, I find, they get stronger through the treatment, because I think a lot of it's because you're taking the fight to the tumor and you're providing lower doses.
Yeah.
And you're not destroying the body in the interim.
Yeah, I mean, obviously the tumors being the main problem site, we need to at least go to those, and try to do stuff. I mean, certainly there's systemic issues, and so there may be stuff that you can use systemically simultaneously, but you certainly should be going right to the tumor site. I mean, I think otherwise it's kind of silly. I mean, imagine like you broke your leg and the orthopedic surgeon say, well, I got some bone strengthening stuff that you can take by mouth. We're not gonna touch the leg, right? It's like
weight bearing exercise. Here we go.
Like that's the same concept, right? You just like ignoring the direct problem.
That's good. That is a good comparison.
I mean, so yeah, I don't know why, medicine went this way where, it's like these cancers, like, oh, but no, let's not mess with the cancer. Well, let's mess with it, biopsy it and stir it up and cause problems. We'll do that and maybe try to cut some out and do this type of things. But otherwise treatment, drugs, no, that's, only oral. It's only IV. You can't put it at the cancer. That makes no sense, particularly with our technology today where we can access, most locations. I mean, I understand, in the 50s and 60s, maybe even in the 70s, but by the 80s and later, they should have been accessing tumors.
Well, that's a good point, because you say most locations, because most locations can be targeted. There are some limitations, right? I mean, a few. Yeah. I mean, clearly, we don't target glioblastomas yet. Though I think you've talked about.
Well, we do a little bit. We're doing some dog studies right now. We're targeting directly, and we're actually seeing some good results in that, and so we are actually getting to where we'll be targeting directly in the brain as well for in the future for cancer.
That's going to be, because I think you've told me those results are really, really positive. That's going to be changing, because this mice model here was, intratumoral ivermectin glioma. So imagine coupling that with PEF.
Yeah. I think in the future in the brain tumors, we'll be doing the same. We'll be going in with like a fine needle right into the tumor, injecting a little bit of drug into the tumor.
Yeah, obviously the issue there is the inflammation, the edema.
Swelling, right? You have to do it lightly.
Yeah, so you have to be a slow, steady approach. So basically, innovation of the Williams Cancer Institute's not just about intratumoral ablation, but it's not just about targeting tumor, not just about intratumoral ablation. It's not just about intratumoral immunotherapy. It's about the combination. It's about the precision, the right treatment for the right patient at the right time. But it's even about bringing in natural and integrative strategies like vitamin C and a repurposed medication like ivermectin. But it's following the evidence to bring the combination, to stack the therapies together, to take it right to the tumor, to empower the immune system to do its job. So it's not just a drug, it's not just an ablative technique, but it's about bringing it all together. And it's about never stop following the science and never stop innovating.
Yeah.
I think, that's just, I can't say it loud enough. I can't say it strong enough. That's what the Williams Cancer Institute does.
Yeah.
The future, you don't have to wait for it. It's here.
Yeah. No, we're trying to get patients the most advanced care now, because obviously there's people, we have the ability, we have the technology, we can do this. This is not, the stuff that we talk about to most people sound like science fiction, but it's not. I mean, we're doing it. We're doing it now.
Oh, it's definitely science. You check out the show notes. That's where you'll find all the science supporting this conversation. Jason, thanks again for joining me. Great conversation as always. If you want to find out more information, you can find us at williamscancerinstitute.com. Jason, where else can they find you? Can they find us?
Gosh, I don't know. I guess, obviously, williamscancerinstitute.com. Obviously got my book, The Immunotherapy Revolution. If they don't know that, they should check that out. I'm sure we have a ton of social media and other stuff, but out there.
We're all of social media, LinkedIn, Facebook, Instagram. You'll find us there. There's a great team that works there. Again, always great to talk to you, Jason. Look forward to seeing you again soon. Have a great weekend.
Thank you. Appreciate it.